I'll request the next moderators to come up and call the panelists. Next is the last session where we have very interesting cases and also a live case, and then obviously much awaited best case award as also. So Dr. Aslan and Dr. Tariq Ashraf, please come.
Thank you, Dr. Bashir. So I will call the chairpersons, Dr. Fawad Farooq, Dr. Sohail Khan, Javed Ahmed, Ghulam Hussain Sumro, Imran Hanif, Shakir Lakhani, Khalid Naseeb, Nasir Rahman, Ahmed Noor, and Shahzeb. Okay, let's start with the first case. I will call Shahzad Ahmed. Enemy, a good is better. You have got 5 minutes to present.
Assalamu alaikum. Bismillahirrahmanirrahim. My case of discussion is retrieval of dislodged stunt from stunt balloon. I am Dr. Shahzad Ahmed, Interventional Cardiology Fellow from Tabba Heart Institute. With my patient was a 60-year-old female diabetic hypertensive, had left lower limb weakness due to childhood polio and had NSTEMI on 10th 2021. Her coronary angiogram at center outside Tabba Heart Institute revealed left main 50 to 6% LAD, severe proximal to mid disease, severe proximal disease in the RCA, severe proximal disease, EF was 45%. Heart team was done at Tabba Heart Institute and CABG was advised, but the patient and the family declined the CABG and opted for the option of multivessel PCI. These are the coronary angiogram images. The slide of our right image is not playing, but the left system, as already narrated, severe disease in proximal to mid LAD and proximal left circumflex. So at the first, we decided to go for PCI of right coronary artery. Right femoral artery access was taken, 6 French GR4 guide was taken, PCI to RCA was started, and in proximal RCA was pre-dilated with 2 into 15 mm alone. Then a 2.75 into 38 mm desk deployed in posterior to proximal RCA at 14 ATM. The stunt was post-dilated with 3.25 into 15 mm non-compliant balloon at 18 ATM. After proximal RCA stunting, we looked at mid to distal RCA looked bad and decided to stunt distally as well to get perfect luminology. Stunt could not cross the proximal part, distal edge of the proximal stunt. So a second wire was taken as buddy wire and tried to deliver the stunt, but stunt again could not cross, and while pulling back, stunt got stuck inside the proximal half of the stunt. Snare was attempted several times to retrieve the dislodged stunt, but it failed. After several failed attempts, we decided to try viral twisting, and after twisting the wire, the whole assembly was pulled back along with the stunt. Then the stunt got stuck in the femoral sheath. Another 0.014 wire was passed through the sheath and the femoral sheath, as well as the entrapped stunt and the 2 coronary wires were taken out. Another femoral sheath was passed over the retained 014 wire. Then took another guide, took the image and post-dilated the RCA stunt, and then left the distal RCA as such. The very next day, the patient was again brought to the cath lab and PCI of the left system was successfully done and the patient was discharged. So the take-home message is adequate planning of the extent of intervention in the target vessel right before the start of the procedure is necessary. And distal stent should be placed before the proximal one. If there is difficulty in the passage of stent, try further dilatation of the lesion or get the help of other devices like GuideLiner or GuideZilla. And keep reminding yourself that enemy of good is better. Thank you.
It's the great message that you should stent the distal segment first, followed by the proximal one. Any comments from the, any questions from the panel?
I think the things are already been described by the presenter as well. But once you are stuck up in such kind of situation, that you have proximally stented a very large stent and now you are deciding to stent the distal part. One thing is got that proximal stent optimally post-dilated. That's again very important. Because bends and underinflated parts which are causing obstruction to your stent to pass through that particular area. And second is know your limitation, where you have to stop. That is the key in the intervention. Don't force anything. You should have a spectrum of force or technique together to find out where to stop. That's the key in this particular. Rest of the messages, you already proper planning, stenting distal, then proximal is important.
Any comments from them?
The thing, we don't go for the luminogram. Most of the time, angiographically, it looks severe. You go for the functional test, either do an FFR, and if the FFR is positive, then you go further for stenting. As we already know, you have fixed the proximal lesion, and then go through that stent is definitely you need skills, and you may have trouble as well.
But sometimes it happens when we are just passing a second stent, it gets dislodged. So the techniques, different techniques of how to retrieve that stent is important. So any questions from the audience? Or any comments from the audience?
Shehzad, do you remember a reason why the distal RCA was not stented first? Or the initial strategy was to just
Our initial strategy was to stunt only the proximal part of the RCA. And when the proximal RCA was stunted and we got the angiographic image, we thought that the distal RCA also looked bad. So we decided to proceed further and go for stunting of the distal RCA.
What was the size of the stent that you couldn't?
The second stunt,
Yeah.
it was again 2.75 into 38.
I hope you give the...
Okay, any questions from the audience?
Any comments from the Zoom audience, Zoom panelists? We are वहाँ क्या हुआ?
Yes, on the community, so help from UK. Shehzad, really enjoyed the case. I think a couple of comments really. First thing to say is, calcification is always our enemy. You can see that the vessel was heavily calcified. I think it was a reasonable strategy to think about just minimal stenting in this patient, but
on an AP cranial view, you would probably have seen that there was extensive RCA disease. I think one of the issues was that the vessel wasn't prepped properly at the outset because you used only a 2.0 balloon to prepare the vessel with pre-dilatation. And generally, you have to remember if you're stenting proximally and then trying to pass a stent distally, as you've mentioned, you really need to reach out for a guide extension catheter. When you were in that difficult situation where you put the stent in, it wasn't moving forward or backwards, what you need to do is take a deep breath because you do have some time to try and rescue that situation. And generally bad things happen in interventional cardiology when you pull. So you need to try and resist that temptation to pull. But you handle the complication very well. The wire, interweaving wire technique, which has been well described using 3 wires, is what got you out of trouble here. So well done on that. I would probably have thought about intervening on the distal RCA as well. I think that lesion was significant. But you didn't want to make the situation any worse. But well done for handling that.
Any more comments from the panelists from Zoom? Dr. Nadeem, can you hear me?
Yeah, I can hear you.
Yeah,
I mean,
please
this is a bit of,
tell us about the case.
this is a 67, तस्वीर लो. ठीक है. This is a 67-year-old had a stroke 2 months back and came in with non-STEMI, and essentially इनकी angiogram दिखाओ शुरू से. First shot. Go on first. All right. So the problem was that she's quite unstable, and as soon as you put the glider, the pressure goes down from 110, it goes down to 60. So she's
Can you show us the initial shots? We didn't see the shots before from the beginning.
This is
Angiographic views.
This is I had to put a wire quickly, and
Can you show us the angiogram, please?
Baseline angiogram.
Yeah. Okay. So can you see this? Can you see the picture?
No, it's just wiring picture. We are not seeing the angiogram. It's just when you wired it.
Next. All right. So now you can see, because I had seen the angiogram, it's not here. So this is the Tini's pre-angio. She's got a 90% lesion in the distal left main, and there's a sharp bend next. There's a very sharp bend of the circumflex, which is quite big. Next. As you can see, there's a very sharp 90-degree, even more bend. Next. You can see the bend by the wire. The normal wire would go. So we used a whisper to. Can you hear me properly?
Yeah, we can hear you quite clearly.
Yes.
Now, we use next.
What's your plan?
So can you tell us the base? Can you tell us the baseline angiogram, which may be memorizing? What's the baseline angiogram?
They don't have
what were your plan after this instability?
That you can well appreciate. The right is fine. The circumflex, the distal left main is 90%.
Yes.
There is a diffuse disease calcified involving a large diagonal in the LAD. And next. So I had to go ahead and balloon this because the patient was not stable. I opened up the distal left main and LAD. Next. All right. So got some flow back in the LAD, and you can appreciate that there's a large diagonal with an ostial narrowing. So that's a bifurcation disease. And there's the bifurcation disease in the distal left main. Next. So you can see there's some disease in the proximal part of the circumflex as well. So next. So I ballooned that as well. You can see, appreciate from the balloon that it's a 90-degree turn towards the circumflex, and there's some calcification there. Next. So this is where we are. Can you just stop this? Stop, hold. Now this is where we are at the moment. So what will the panel think? What do you want to do?
In conclusion, we can say that's a disease of left main, shaft, distal, proximal LCX, distal LAD, and then a diagonal. So you're dealing with two bifurcation, one at LAD circumflex and one is LAD diagonal. Circumflex ostium is looking good, but there is disease distal to the ostium which we have ballooned very severe. So I think left main, LAD and circumflex, they both need elective stenting. Now you have to decide regarding diagonal whether you're going to put in a stent or keep it a provisional. I would keep that provisional and elective 2 stenting of left main to LAD and circumflex. That would be my plan for this patient.
What about Dr. Sohail? Any comments from you, Dr. Sohail?
Yeah, so it's Nadeem, hi. It's a challenging case, and I think one of the reasons why the patient probably decompensated is that you've probably got significant disease at the ostium of the left main stem here as well. So when the guide catheter jumped in, you probably saw damping of and dropping of pressure. So what we're dealing with here is a calcified, left main stem involving the distal bifurcation. My concerns here is, as Nadeem has shown, that the balloon hasn't inflated very well going in from the left main into the LAD, and I just wonder whether we are going to need to think about some calcification modification tools here, either cutting balloon or even possibly rotablation to try and deal with this bifurcation. There is, of course, another bifurcation, the LAD diagonal, so there is disease at the ostium of the diagonal as well, so that we're going to have a strategy for that. But I think we're going to probably need to think about a 2-stent strategy to deal with this distal left main stem disease, probably with calcium modification.
And especially considering the instability rather than DK crush, I think we should maintain first the left main to LAD flow first. So I would keep, if the patient is unstable, the tap would be the my
Dr. Sale, what do you think about doing an IVUS before jumping to further sending, seeing the calcium and regarding seeing the left main?
I mean, IVUS is a possibility. I mean, the nice thing here is that you've now got 2 wires down the vessel, and you're able to back out the guiding catheter. And once you do that, you will find that the pressures will stabilize. So, IVUS is absolutely mandatory, I think, in this case, to get some information about the bifurcation, because it will help plan your strategy going forward. And so I would IVUS into the LAD, but also from the circumflex back into the left main stem to try and understand what the distal bifurcation is like, and then decide on stent strategy at that stage.
Dr. Nadeem?
Hello, Nadeem. We couldn't see the cine pictures clearly earlier. So can I know what's the status of circumflex ostium? You talked about distal left main, but what about circ ostium?
Yes, sir, there was, go back, go back. Go back, go back, back. Yeah, okay, stop. So this was before the balloon. You can see there's a tight narrowing at the proximal part of the circumflex.
Now it's clear.
All right, next करके आखिर पे आ जाएं. अच्छा, my thing with IVUS is that personally, I know there's calcium, I know there's going to be severe disease. Because there's damping, it could be a transmissional effect because of the distal left main, or there could be some osteal disease. So my interest in IVUS is essentially limited to the left main. There's a 90-degree turn. I know there's calcium. I'm ready for a rota, but to keep this, because of the instability of the patient and the criticality of the disease, I think we have to treat the patient in a way that safety is also, not compromised. So my issue would be, I would like to put now, what I'll leave to the panel is, I was thinking of doing a Collot here. Because of the angulation of the circumflex, I think I should put a stent from the distal left main or covering the whole left main into the circumflex. The only problem here is the trackability. And once I've done that and secured that area, then I can fix the LAD bifurcation after that. So the stent would, the next stent would then be either a DK Collot or a Collot, standard Collot into the LAD. What do you think about these? Or DK crush here would give me a problem with V-axis to the circumflex, although that may change the angles and I might be able to get into the circumflex easily, more easier than I had initially. So I'll leave that to the panel. My own view would be to do a Collot.
So what you're thinking about LAD, would you put a single stent from left main to mid LAD, or you're planning of 2 different caliber stent, first covering mid to proximal and
Collot to the circumflex. I will
that is, that's okay with that you're taking care of the bifurcation with Collot. But what about LAD? Would you keep just 1 stent in LAD from left main to mid, whatever the lesion is, or you are planning of 2 stent in LAD?
That I will see. I will see where the stent lands, because in Collot, then I will have a chance of seeing I would probably might do a provisional. You might have, in which case one has
Because
to remove
why
the problem
I'm-
with rota is extended the left main, then I would have to, and if there's a problem later, in order to save the diagonal, I might rota the LED afterward by using a guide liner, keeping the guide liner at the ostium of the or after the stent in the left main, so that I can then rota the LED. That might be a good strategy to do a stent to the circumflex, then use a guide liner and go into the LED with a rota bar to that guide liner and then fix that LED. What do you think about
Dr.
that?
Suhail?
Nadeem, two questions. First of all, which French guide you are taking? As you were telling that you do most of left mains even with 6 French. So what says? So what size?
Standard 6.
Is it 6 French or
What?
7 French? The guide.
I mean, right or wrong, I have 99.9%, 99% cases irrelevant. I just use EBU3. And in certain cases, when I can get access, I use AL. So I don't use any other guide apart from EBU3 and AL.
Can
But
you show
in
us
the
the
left-
distal view, distal LED view at where you'll be keeping your distal landing zone in LED?
Nadeem,
can
can
you
I-
show us the distal LED view?
आगे पीछे जाएं, पीछे ये
So where,
All right.
what will be your landing zone here in LED? It's beyond septal or
don't
before?
understand. I mean, once I've sent it into the circumflex, then I am going to leave a small amount of stent in the, if I'm doing a collot, then my landing zone has to be down. I mean, I will be covering and quite distally, so I might use a 38 or whatever stent from the left main to the LED.
Because
Uh,
that's
Dr.
why
Suhail-
I'm
Dr.
asking
Suhail-
about culotte, because for culotte you have to have both the vessels of almost a similar kind of diameter. So if you are keeping, because distal, mid to distal LED looking like around 3, maximum the stent which will be take, it's 3, and left main you have to keep a lumen or at least 3.5 to 4 there. So I would suggest, if you are thinking of doing culotte, you should be stenting the mid to proximal LED with a different caliber diameter stent, and then doing culotte with a stent which you are planning for left main to circumflex, keeping a same diameter there. That is my thought, if you're thinking of culotte.
Nadeem, can I have a spider projection once again, the basic, so that I should know the angle the LED is going. So what about a reverse tap? As Rosy showed yesterday, he started from circ to left main and then a reverse tap from LED to. It's a good angle for a reverse tap, and that will take care of this discrepancy which Fuad is talking about.
And even that reverse tap can be done from left main to LED main stenting, and then this tap would be done to the circumflex.
Yeah, but stenting, then wiring the LED will be easier if he does
Yeah,
it
in
from
this
circ
case.
to left main.
Okay.
And the circ is a bigger size vessel as compared to LED.
Agree.
The other important issue here is because the angle is not so much favorable for the culotte, the angle I think is more than 70. So my first preference strategy will be the DK crush or the TAP. Because if the angle is more than 70, I don't think so culotte is so much favorable for this type of.
Dr. Suhail, what would be your strategy regarding lesion preparation and the techniques, whether culotte or DK crush? How will you approach this case?
So I think what we're seeing now is the IVUS one. So I think this is going to be really helpful in determining whether we need to do any calcium modification here. In terms of two-stent strategies, I think the operator needs to choose what they are most comfortable with. My two-stent strategy of preference is the DK crush. The reasons why I like the DK crush is basically I will not lose wire access to the main vessel. So I would consider the LED to be the main vessel. The problem with the culotte is that if you're going to stent into the circumflex, you're going to have to, at some stage, pull out the LED wire And there are instances when operators then have struggled then to get back into the LED rewiring, and particularly if you've got calcium there, then wiring will become more of a challenge. So, I think you've got to go with what the operator is most comfortable with. I think in terms of size discrepancy, there is size discrepancy here in terms of the vessels, so you can think about a culotte. The nice thing about DK Crush is it works regardless of your bifurcation angle, so you can do it in narrow angled bifurcation, but also wide angled bifurcation as well. So, that's the reason why I choose that. If you're looking for a bailout strategy, it's not unreasonable to think about stenting after you've prepared the LED left main stem from LED to left main stem, and then think about rescuing the circumflex with a tap as been suggested already.
Can I just interrupt now because there's a lot of noise and okay. So I get your point, Sohail. My most comfortable technique is DK Crush. And so can you look at the IVUS, static distally? Are you focusing on the IVUS pe kare focus? Nahi? Acha.
Center,
so you can see the
mechanism. Yeah.
IVUS now on the main screen. This is distal. So the artery is 1 to 3 millimeter, 3.2, 1 to. So that's distal coming into the proximal part. There's a lot of plaque, there's some calcium. I can't see too much calcium all over. There's no napkin type of calcium. Now there is this calcium here. Now we are into the left main, which is around 4 millimeters. Okay, so this is the left main. Sohail, any comment? Because now it's a live case. I will follow the panel. I can do a collot, we can do other things. I think probably in retrospect, in hindsight, I think probably because of the criticality and the unstable, you see our pressures are 130, 120. I would not like to leave the LED without a wire, and basically because of that alone, I think I will go with the DK Crush.
Yeah, I mean, what we've seen on the IVUS, as you've said already, is there's extensive plaque burden within this LED left main stem complex. Fortunately, there isn't much calcification, but you've got to make sure that you've really prepared that LED and circumflex properly with non-compliant balloons before you think about putting any stents in. So I don't know, that first balloon that you had, I think was a 2.5 balloon, possibly 2.520 into the circ, but just make sure you've prepared this with, at least 3 or 3.5 non-compliant balloons to make sure that your stents will go down.
But sir, regarding DK Crush, it will take more time, more dye, more things. Considering the criticality of patient, I would suggest go with TAP rather than DK Crush.
All right. Okay, ACT kitna hai? ACT?
More time, more dye, more DK Crush.
Well, what we know is that all 2 stent procedures will take up more screening time and
Dr.
also
Tariq
take up more
Siddiqui
contrast
from US,
as well.
please come.
But what we do know is that, in terms of bifurcation strategy, particularly for the left main stem, a 2-stent strategy is better than a single stent strategy when you've got a complex left main stem bifurcation. And certainly we are dealing with a complex left main bifurcation here. We've got extensive disease at the mouth of the circumflex extending more than 10 millimeters down into the circumflex. We've got calcification and we've got heavy plaque burden here. So I think a 2-stent strategy is going to give this lady the best and optimal results.
There's a significant large diagonal branch also that has osteal disease as well. Are you planning to protect that or leave it alone?
Provisional. Provisional approach to that.
Dr. Tariq Siddiqui, you have seen the case. Any comments from you?
So the key thing in this case, I think, is a guide support. And as we talked about, to prepare the lesion better. I feel that again, as Suhail said, the choice should depend on how you're comfortable, which one you want to, which one you're used to of doing it, either mini, DK, or culotte. I think from my perspective, preparing with other, any kind of device we use with the rota could be, have a guide liner support, because as you all talked about, this is two-stent technique, you need better support. I would go for the DK crush in this case, especially knowing the angle of the left circumflex coming off. I think LED is more straighter, as you all said, coming all the way to the left main. And I do agree that culotte could be an option, but again, the size of the vessel is key, and there are some data favoring more with the DK crush from a stent thrombosis and stent stenosis perspective.
All right, so essentially, I think guide support in this case, there are a couple of poor man tests, and I've done those tests, and I think the guide, I kept the guide quite back, and then the used balloon I used to get into the circumflex, and I don't think the guide support would be that much of an issue in this case. But yes, I think that I want to first secure the LED, and the only problem is whether I should rota it now. How many people think that I should rota it? In which case I would have either rota the LED, not the left main, and leave the wire in the circumflex. That wire is Whisper, so I can do that. Put a guide liner across.
Well,
how many would pay?
Because now you have already 3 wires, and I think you can do rota beyond the diagonal by putting your other things. I would suggest to try with NCs and see the behavior of non-compliant balloon, whether it's opening up the lesions or not. If not, then certainly you have to go to rota, but then you have to take out your wires.
Dr. Suhail and Dr. Tariq, would you do a rota or a non-compliant balloon?
I think challenging thing would be the 90-degree angle of CERT. So I would definitely prepare the lesion very well before anything else. As I said, I think we should rota. Could be you might have to take the wire out of the LED, do left main to CERT, because that looks more calcified visually. I think I was looking at it, it was from the CERT to the left main. I might have missed it. And it's almost like from 5 o'clock to 2 o'clock, it's all calcified, the only small area which was devoid of non-calcified. So that will be easier, especially after the stent, if you try to do post-dilatation, that will help you for a better transition too.
Yeah, there is more calcification in the left main, more close to the left main. I think rotational atherectomy will be good for left main.
Dr. Suhail? Dr. Suhail?
I have to say I would probably not do rotablation here, and I think what the IVUS has shown us is it's given us important information here. It's shown us, yes, there is calcium, but it's also shown us that this calcium is not circumferential. So I think I would probably think about putting NC balloons down here, 1-to-1 sizing, and see if they expand appropriately in 2 views. And if those balloons expand appropriately, then go ahead and treat with a stent. Of course, if they don't, then you may have to change your strategy and think about rotablation. But as mentioned already, you're going to then have to take out 2 of your wires to be able to do that.
The other thing I want to mention here, we will just, because if we want to do rota, we may have to pull out the wire from the circumflex. The other thing, if we just want to keep the wire here in the circumflex and want rota from the left main to LED, we may have to use the guide liner or Godzilla, etc., just to not burr the other wire, especially in the left main. And the guide, I think they are using is 6 French, and the big, large diameter Godzilla may not be able to deliver. The other important thing, if you want the burr size of more than 1.5, it also may be challenging just to through. So I personally think that we may have to prepare the lesion with the NCs, cutting bearing, and all the things.
Nadeem, you want to try that rota with the wires in place?
So you have passed a stent. And did you prepare the lesion with a non-compliant balloon first?
I think doing rota with wires, I think that won't help because main calcification is at distal left main and the proximal LAD part. So just doing rota mid LAD won't help that much.
Suhail, have you ever done leaving the wires in place, rota?
I have. So there's a technique known as the ping pong rotor technique. I've only done it with a second guide in place. And when you do it, you have to have a microcatheter protecting your side branch wire, whether that's the circumflex or the diagonal. And you do it when you're concerned that the side branch is going to go down. You have to go with a big
I always
guiding
thought that
catheter.
you can't do it, but Mohamed the other day was saying that he has done it and he has no problem leaving the wire in and just doing the rota to the other vessel.
I mean, if you're going to do it with a single guide, that is an option, but you have to go with a large guiding catheter, something like an 8 French, to be able to protect your side branch with a microcatheter. Because the concern is that you'll just shear off the side branch wire otherwise.
Yeah. Okay.
I was discussing this offline with Bashir and told him that I have done a couple of, or one case, using plastic wire, plastic jacket wire. Before I did that, I made sure that I used it outside and so that it doesn't shear off in a confined environment. And it didn't. And then I asked a few people and did it, including Colombo. And it doesn't make, but yes, this is not for teaching and I would not recommend it, but if you get stuck and if it's absolutely necessary.
Okay, Nadeem, I think what we're going to do is we are going to go ahead with the cases and we'll come back to you in few minutes to see how you are doing. Is that okay?
Okay, so we are finished. I'm just going to rush back in about 10 minutes.
Okay.
The PT staff, Dr. Naeem, Dr.
Yeah, they can
Nabitullah,
complete.
thank them.
Nadeem, what have you done? You have put a stent there from left main to LED?
Because I'm going to do a DK crush.
What about the distal? It seems there is something at the distal edge. There was haziness also there.
First, but I wanted to first secure a 30 millimeter stent. Then I'm going to put another stent. And then I'm going to fix the LED distal bifurcation now that I've protected the left main. So I'm now going to do a kissing balloon, etc. on the distal, fix that diagonal bifurcation first, and then worry about the circumflex. So I'm going to do 2 bifurcations separately, keeping totally separate, so that I don't have to worry about the left main and the pressure damping.
Are you happy with? Are you happy with the distal landing zone of your stent?
I stand in the LED distally and then work on the LED and diagonal. And once I've finished the bifurcation of the diagonal and LED, then I'm going to work on the left main bifurcation. This is what I would recommend in unstable patients because now the pressures are fine. I can have my guider in. I can do whatever I want, not worrying about distal left main and this left circumflex. I'm going to do the LED bifurcation first and then concentrate on the circumflex bifurcation. Now, ek aur stand do.
Okay, we'll come back after 10 minutes. And there's an announcement. Black Corolla BST 224 नीचे खड़ी है जिसकी भी है हटाएं उसको हटा लें वो emergency ambulance वहाँ से गुजरनी है कोई है किसी का Black Corolla BST 224.
And also another announcement, last chance to enter and go and visit the exhibits on the website to win a tablet, which will be announced shortly. So those who haven't done it, they should quickly go and visit that virtual conference and also click the exhibit site and go in there, and then you will get a chance to win the tablet.
Okay, the next person in is Mr. Abdul Salam.
Assalamu alaikum, everybody, and thank you for giving me the chance to stand over here. I am Dr. Abdul Salam, an interventional fellow from Tabba Heart Institute, and I am here to just take a few minutes of your attention to tell you about the very first case ever in Pakistan. It's a TAVI, but this time it's from the axillary artery. So we always start with the name of Allah, so Bismillah ar-Rahman ar-Rahim. So my case is a case of 75-year-old gentleman. He's a smoker, recently found to have an atrial fibrillation on an ECG, which was done routinely before his prostate surgery. So subsequently, he presented to us. We have done the echocardiography. His EF was low with 43%. EF, which was global, and his aortic valve was suggestive of low flow, low gradient, likely severe aortic stenosis with valve area of 0.5 square centimeters, and his peak velocity was 3.5 and mean gradient were 39 with pulmonary artery systolic pressure of 35. We have checked his aortic valve calcium score, which was very high, more than 4,000, and luckily his coronary calcium score, just to mention, was 103. The need for aortic valve intervention with SAVR versus TAVR was explained to the patient and the family. We have called our surgeon on board as well. It was discussed, and the patient has expressed his complete rejection for the surgical option, and he has opted for TAVI. So for that, we have gone ahead and we have got the CT TAVI protocol, which was done. So a lot of information over here. I'll just make it short. The annulus size is around 24. If we look at the sinus of Valsalva size, the height of the coronaries, and everything seems to be very much adequate and promising, but we were very much disappointed when we have seen the size of his femoral artery. I'll just show you what we see. The right and the left femoral arteries are down in the screen at the both corners. So his femoral arteries both are less than 6, around 5.8. Still we can negotiate with that, but if we go more proximally to the iliac artery, which are expected to be even larger, unfortunately they were even smaller in diameter, which is around 4.1 and 4.2, and that makes it impossible to be considered for such a huge procedure. So we have gone through the literature. Patient is insisted to go for the procedure, and we have to look for another access for our upcoming procedure. So we have seen internationally transapical, transaortic, subclavian, axillary, transcarotid, and the most recent was transcaval. All these routes were done in different centers of the world, but not in our country. Looking at these options, axillary and subclavian with all the expertise and resources we have over here, they were more promising for us. So back to the CT, which has been done already. So looking at the axillary artery, the size is around 6.4, which is more than 6. And the more proximal we go to the aorta, the subclavian is even bigger, 6.7. And this is exactly what we need to maintain, to keep around 18 French sheath, which is required for our procedure. So before proceeding, we have to see what are the possible complications with this route. So again, there is no RCTs on this axis, but different registries in the world have mentioned a mortality of 30 days mortality of around 4.4%, major vascular complication of 3.1%, and the stroke around 5.4%. We have put these data in front of our patient, and with a big smile, he said, please go ahead. I'm taking the risk and start with Bismillah. So the patient was prepared for the procedure. We planned for coronary angiogram and TAVI. As we see, his creatinine and blood counts were normal. So we have taken a left femoral axis. This is not the primary, this is the secondary axis. As we see, there is a big tail in the abdominal aorta. We are doing an angiogram. There is another sheath, if we can appreciate, in the left femoral vein, which we are going to use for our pacing wire. So maybe we were a bit overwhelmed. This is the first procedures, and we were worried how it will go. So unfortunately, lots of important shots were not stored. But still, I think the important idea can be delivered in these. So we started with the angiogram, and grossly we can see that both left and the right systems are non-obstructive. Okay, so the important part is how to take the access from the axillary artery, and this is the first time we have seen different procedure, but we have done as following. So we have put a JR catheter in the left subclavian, and we have ossified the artery, and from outside with a locator, we decided where is the point we want to enter from, and with the sterile marker, we have pointed that area, and we have introduced the needle, and the needle went inside the body under the guidance of ultrasound. So ultrasound was guiding us where the needle is going, and we have punctured the artery, and we have no issues with that, and we have maintained initially 4 French sheath as we see over here, which was upgraded subsequently to 18 French teeth after dilating that. Now preparing for the closure, because we were planning for a complete percutaneous procedure, so a standard ProGlide was actually implanted over there. So preparing for our valve to come, as we see, so the pigtail is in the root of the aorta. We are doing the aortogram, and our pacing wire is in the RV apex. So our valve is being prepared still outside the body, and over here to facilitate the entry of the valve and to optimize the result, we have actually dilated the aortic valve with a 22 millimeter balloon. So our valve has reached its destination and is being implanted. It was a co-valve, self-expanded, and it was deployed with rapid pacing during the implantation as per protocol. And luckily, this is the final result. So as we see, a well-seated valve in its right place, coronaries are not compromised at all, and by the grace of Allah, almost no regurgitation. So the valve implantation went smoothly, we have no issue, but now the challenging part is the access and how to secure that. So we have planned that already, and we have done a balloon-assisted sheath removal. So again, we don't have lots of picture, but I can just explain it. So we have a BTA balloon, which is 7x40. It's like over there at the site of the entry of the sheath, and the ProGlide are tied, and the sheath comes out while inflating the balloon to minimize the bleeding, and the result was amazing. So we had no complication at all, almost no bleeding, not even hematoma, and the hemostasis was secured, achieved. So just to mention, invasively, before the procedure, the gradients were 41 through the aortic valve, and after that is 6. At the end of the procedure, we have given a synchronized cardioversion, and that has restored the sinus rhythm of the patient. No cardiac and no vascular access complication at all, and post-procedure, the patient remained clinically hemodynamically stable. He was extubated the next day. Next day, we have done an echocardiography, which has shown that the core valve is in the right place, well-seated, no issues. The velocities and the gradients were quite normal. And thank you very much for your attention.
It was a nice case. So my 2 questions are, number 1 is, you access the axillary artery fluoroscopically. What about using an ultrasound?
Both. We
guided?
use both, fluoroscopy and ultrasound.
Okay, you did both.
Yeah.
And how did you completely assess that your bleeding has stopped from the axillary artery ballooning, and you said you put a ProGlide wire?
We took the pictures. I think that we may not have recorded, but after the balloon was removed, we took the picture also.
How much time it took?
What?
Ballooning and just checking it?
Balloon was mostly actually kept initially. We had the ProGlide there, and while we kept the balloon there already in that place, so that during ProGlide placement, there's a lot of bleeding sometimes happens. So we inflated the balloon during the exchange, and then we put the ProGlides, and when ProGlides were done, we left the balloon just for a few minutes. I don't remember exact time, but there was minimal ooze, so that's why we kept it there, and after that we checked it again, it was fine.
Because femoral is superficial and it's a bit deep.
Yeah,
so
exactly.
Any question from the panelists?
What are the fluoroscopic landmarks to access the axillary artery?
Islam, you want to say, or I can
Yeah,
tell?
so basically, just we see the first rib. So outer of the first rib, actually, we expect the first portion of the axillary artery. So we have seen that. Again, unfortunately, we didn't store this. So with any metallic instruments like a needle holder or an artery forceps, we have just like, point that area where we want to enter from, and we just mark it on the skin. So that was an entry point, and as I have mentioned, later the ultrasound has come and that has guided the entry of our needle.
So basically, there's a branch coming off. I don't know. We could go
the subscapular artery.
Yes, subscapular artery. So you just want to go beyond that, not at that. Again, there are different tricks. This is one of them. Then there are some other people who say that maybe you should aim for the middle of the 1/3 and 2/3 of the humerus. So in that area. But the branch is the most important. You want to just go beyond the branch and save that branch, because the risk of bleeding is become significant if you.
What my understanding is that if you are medial to the glenoid cavity, then you will be avoiding the subscapular artery, and that will be the idea to puncture the axillary artery.
Right.
Yeah,
Case in a way
can I just come in with a couple of comments? Abdul Salam, a great presentation, and Bashir, congratulations for doing this case. It's the first ever transaxillary case in Pakistan, so really well done. So from a anatomical perspective, when you're doing this, what you have to do is you're aiming for the second part of the axillary artery. So you want to avoid going too near the femoral head, the humeral head. So you're aiming basically to go between the thoracoacromial and the circumflex humeral artery. You don't want to, if you go too close to the circumflex humeral artery, then of course you risk avascular necrosis of the head of your humerus. If you look at the literature on this, it's a very good technique. People have now pretty much abandoned transapical or direct aortic access because of the complications associated with that. But the complications from a transaxillary are very similar to that you get in a transfemoral approach. So it is probably the access artery of choice if you can't get in from a transfemoral approach. The only other thing to say is that there is a little bit of a learning curve with this as well. So you have to have covered stents available in your lab. The early literature suggests that in 1 in 4 cases you will end up having to put a covered stent in, but subsequently the complication rates drop and your use of covered stent is less than 4%.
We our second case, we did a
Can I
second
make a
case
comment?
also. Just want a quick comment, number before you go. Second case, actually, we had a problem. It was a obese lady, and we were unable to actually deliver the ProGlide. One was okay, but second was unsuccessful, so it kept bleeding, and we kept the ballooner over there for a while, but didn't stop, so we had to put a covered stent. So we made sure that we had covered stents in the cath lab before starting the case. You're absolutely right. Things can happen, and you have to be prepared for the worst.
So I just have a comment, and I just wanted to, a great case. I just want to draw attention to the original thought process that when you looked at the femorals and the iliacs, they were very small. So question is whether were they diseased, and could you not fix them and create your passage so that you go in a routine way? Just put some stents there, widen the passage. I've seen that people do that for TAVI in Europe before switching to the axillary approach.
So basically, intravascular lithotripsy can be considered to facilitate the delivery, and in different centers they have done that. So it's IVL assisted delivery of the aortic valve system, but unfortunately we don't have this available in our center.
No, I meant that you could create the passage in the sense that it was a small femoral artery, small iliac arteries, and they looked as if they were diseased. So you could actually put stents there and widen the passage.
It's
do you want to do that with IVL or just a stent? It's not recommended.
It's not disease. It was basically the size was small. It wasn't disease. So in a small size vessel you could, but unnecessarily putting stents in there is not recommended. I don't think so.
It would be strange to have such small sized vessels.
So if there is no comments from either panelist, I invite the third.
what technique were you using for implantation? Are you using cusp overlap techniques? Or what was your angle of deployment?
Sorry, just one.
So what angle did you use to deploy the stent? Are you using a cusp overlap technique, which is recently in the last few years we have been using?
Actually, we have been using, if we go on the report, a lot of time that's cusp overlap technique, and they tell us what angle the cusp overlap is there, and we use that angle.
Okay, our third.
Let's quickly show the end result. I think they are done over there, and then we can continue with the cases.
Okay, Dr.
Can we take us now? There's Dr. Nadeem and Tahir are on the way here. Okay, so let's do the next case, and by that time
Fine.
they will get ready.
Okay, Dr. Sanam Khwaja, please come on the stage. Managing a mid-migrated dislodged expanded stent.
Good afternoon, everyone. Thank you very much for giving me opportunity to present this case on such a big forum. My name is Dr. Sanam Khwaja, and I'm an interventional cardiology fellow at National Institute of Cardiovascular Diseases. Thank you, Dr. Fawad, for mentoring the case. So the case is about a rare recognized dilemma in the cath lab, an innovative technique. All right, so my case is about a 65-year-old female hypertensive presented with a history of chest pain for about 2 hours. And the ECG done revealed inferior wall MI. So patient was hemodynamically stable, and the consent was taken, and patient was taken in the cath lab for the primary PCI. So the right radial axis and the angiogram was done with the MP catheter, and we could see that the MP catheter is quite deep, and the stump of the RCA is visualized. So what next we did was diagnostic shot for the left system, and they shown that the left main is non-obstructive, and the left circumflex is non-obstructive, whereas there is a severe disease in LAD. So what we plan next to wire the RCA and the aspiration thrombectomy to be done. The aspiration thrombectomy was done, and what we see next was not expected. So when we took the next shot, we see that there was a spiral dissection in the RCA, which was extending to the proximal to mid, right into the right aortic cusp. And so our plan was to basically fix the dissection. And if we could see right over the top of the screen, so we plan to occlude the distal part of the dissection first, and a stent of 3018 was deployed, and you could see that there is a stent of 3018 which is in place. Still after deploying the stent, we see that there is an uncovered area in the osteoproximal RCA, and that's why we plan to put another stent. And right at the left of the screen, if you could see, we post-dilated, hold the stented segment with 302L NC, and that was the final result which we could see. So while we were attempting to flare out the final part of our osteoproximal RCA with the NC, a nightmare happened. What we seen? We seen that the stent got dislodged proximally into the aorta. And we planned next our strategy, and there was intelligent move by our operators in the cath lab. And what we did, we took the the expanded stent back on the guider successfully. And then, in the meantime, we planned that we will fix the area of the uncovered stent first, and then we would be handling up with the dislodged stent. So in the meantime, we plan to cover up the dislodged stent first with the 302L 12 mm stent, which is deployed on the remaining part of the lesion. And this was the final result, which is shown in the screen. Now, our next move was to secure that expanded stent over the guider. So we plan to deflate a balloon at the tip of the guider in order to keep this stent safe within the guider and, dislodging it from anywhere else in the circulation. So this is what you could see here. There is an inflated balloon at the tip of the guider, and you could clearly see that there is an inflated balloon at the tip of the guider right at the level of the right subclavian artery. So what we planned first, our first strategy was to take this stent out through the radial route. But at the level of the right subclavian artery, that as we have demonstrated, the stent got stuck over here. So for the patient safety, we planned to switch the route, and we did a femoral route then. And through this femoral route, we advanced the gooseneck snares, and we tried to, assemble out whole the assembly with the stand, with the wire, throw the femoral route out. But when we attempted to snare out whole the assembly, the wire and the balloon came out, but its stent still held it in its position. But it advanced a bit down deep into the aorta through the Drake catheter. So you could see very clearly, we are demonstrating that the wire and the balloon has been advanced through the femoral sheath. So then we separately snared out the stent through the snare separately. So the take-home message from this case is that complication make us learn. They has to happen, and the successfully treating complications can learn and prevent many in the future. We all know that the short FCRs are at the risk to dislodge the stent, so one has to be very much careful while doing these cases. This case illustrates an innovative technique from the dislodging stent. So the best view has to come after the hardest climb. Thank you very much, everyone.
Any comments from the panelist? Dr. Tariq?
Sorry, I may have missed, but I didn't understand, like, once you pulled out the guide with the snares from the femoral root, so where was the stent at that time?
This stent was actually riding on the guider.
Okay.
And while we were trying to, what we did, we inflated a balloon at the tip of guider in the wire to prevent this stent to come into free circulation.
Sure.
While we are taking it from the subclavian, there was a bend there. It stuck there. It wasn't being able to really retrieve from the radial route. So this whole assembly is there. We take a snare, pulled it towards that. In that moment, that's once this stent started coming down to the tip and came to that balloon, and that was snared with that, and that came out through that. This was the whole story. Initially, it was stuck there, and subsequently, it was a free-like thing, so it's because of gravity and the blood flow towards downward, it's come up to that balloon which was stuck in the mouth of the guider. So it's stuck there, and that helped us in snaring it down to the femoral root.
So you were using 6 French or 7 French femoral sheath, because if the
in
balloon
femoral we take 7 French.
Okay, because if the balloon
radial was 6 French, and femoral we took 7 French.
But the balloon was expanded at that time, and the string was also expanded.
No, once it was snared,
the
balloon was uninflated, and we took that.
Okay.
Actually, this stent, when we uninflated that balloon part, that snare captured the stent, and it was snared out.
Okay. So there was some difficulty in just snaring out the stent from
Actually,
the
the
femoral
problem
sheath.
arises when you come to the sheath.
Yeah.
It may dislodge to the distal circulation. And not actually remember, it was a case 2.5 years back we did. So I don't know exactly, it dislodges into the lower circulation, or we been able to take it out from the, it's not actually, I am remembering that.
What is the problem? Usually the problem is...
But usually 1 or 2 cases we did like that, we just brought it to the lower limb circulation, and it was
Yeah.
lost there.
Yeah,
So
there
one
are
or two cases,
two
so that
problems.
means you are doing, this happening quite frequently.
There are actually two problems. Just one comment.
We
There-
have people in our cath lab in different
Experienced
learning
now.
different learning curves.
Good.
Started for 1 year
Good.
resident, 6
Good
month
experience.
resident,
Okay, I think,
2-year resident.
sorry,
So
they
you
are-
come across so many things.
Sure.
With that
no, no,
kind of
we
experience,
understand.
people
I
at
was just
different
joking.
level of-
Thank you very much. I think we have, thank you. We have to just quickly see what's going on over there in the cath lab, and then we'll move back to the cases.
Dr. Nadeem, you will wrap up from here or?
All right, so I'm back here. Basically what we did was, we converted this, instead of DK crush, I put a stent from the left main ostium all the way to LED, then put another stent in the LED, optimized the distal LED. So basically it became a provisional. So the diagonal was open, we thought we leave it, or I told them that if we need to, we can kiss it, but it was still open after all the optimization with NC balloon, 3 millimeter NC balloon. We, at a high pressure, we did in the LED, and then I rewired the circumflex and said that if we need to, we can always do a tap there, or you know, even you can put a, you can do a kind of a culotte, but or a mini crush, because it was 90°. So we could do a T-cone, we could do a tap, but basically then from a DK crush 2-stent strategy, we converted it into a single provisional. So let's see what's happened.
Yeah,
this
Naveed
instant.
was.
नवीद आपको आवाज आ रही है आप जरा दिखा दें आखिरी शॉट
I think the
because
kind
the
of
patient was very unstable, and this is why you know, every time the guider went near, and this is just a demonstration that you can use XB, and I think it is much better than JL for these for the excuse that people make that you, because the short ostium. No, I think it's much better to control the ostium of the left main and the guider through the wire. So the best thing is to jail a wire and then just push on that jailed wire, and the guider will be, and it will be coaxial and it won't damage anything. So you can keep the guider out by just jailing a wire in the diagonal and just tugging on the wire and keeping it.
But I think the kind of lesion we ballooned in the circumflex, I think this will need a stent subsequently, maybe a tap or provisional maybe.
Yeah, just remember each lesion has to be treated. People forget कि मैंने फारूकी साहब के पता नहीं कब के cases देखे हैं जो ज़माने वो balloon करते थे 15 circumflex behaves best with balloon. If you get a less than 20% residual, then you don't need to stent.
Dr. Sohail, any comments? Dr. Sohail?
Yeah, so well done, Nadeem. That looks great on the angiogram. I guess the case really tells us that you do think about changing your strategy, because the initial strategy was a 2-stent strategy, but you have to bear in mind that the patient may become unstable, as what happened in this scenario, and going for a single stent strategy from LED to left main stem to rescue the patient on the table clearly was the optimal treatment for her. Just need to make sure that the stent in the left main stem is optimized. So it looks like we're going in with a large balloon here. So you need to make sure that you've done an appropriate pot to oppose the stent. And if you've got the IVUS available and open on the table, and you might as well use it at the end of the procedure as well, just to make sure that there's no distal edge dissection. You haven't landed into any atherosclerotic plaque, and the stent throughout its entirety is well opposed to the vessel wall. I haven't seen clear pictures of the ostium of the circumflex, but you know, you've got TIMI3 flow in there at the moment. You can always come back and reevaluate that at another stage, depending on how much contrast and time you've spent doing this procedure so far.
Yes.
But really well done. It looks like a great result.
Sorry, can I just make a quick comment, because all the fellows are here. I think when you look at, if you go in the jungle, don't please forget to look at the trees. When you do these kind of complex lesions, take one lesion at a time. So diagonal LED, do it on merit. Don't do a double jail on the diagonal. That's the first aim. So use your stent lengths according to that. When you do now, take each, if you're doing double bifurcation, left main, don't mix it together. So you have to take each lesion at a time and treat it, and obviously keep in mind the clinical condition, the dye. And what people tend to do is that look at the whole thing and they say, oh, left main thi, chalo ye ho gaya, usko chhod do. Now I would probably fix that circumflex. My view would be to fix this circumflex with another stent, maybe a tap. Naved, aap kya kar rahe hain? What is the plan?
Can you hear us, sir?
We can hear you.
Okay. So we have gone and we did port to left main. Now we have planned to go for IVUS again from LED to left main. Then we'll plan for SERC. So our plan is to go provisional after doing the IVUS from LED to left main. Then we'll decide about the SERC.
Good.
So now we did port.
Have you recrossed your wire into the circ, or is it
Yes,
still?
yes, they've
Yes,
recrossed. They were recrossing. They did recross.
So that's why we went with foro balloon. We did port with foro balloon. And now we'll do ours, then we'll try again to rewire again to the SERC.
And Dr. Tariq, would you?
Well, I think it was a good, I think as Dr. Swale mentioned, that initially we planned for the two-stent technique, and as the case, patient was not stable, that's why converted to one stent technique. And circ looks tight, osteally, a lot of calcification too. I think needs to be addressed at some point down the road if patient has already used a lot of dye. Now, just one question. What was the LVEF on this patient?
That was normal.
No.
But obviously, that's why you saw us taking so much dye. This is extremely important question. I always start every single case that I do angioplasty. I always do an LV angiogram for free in a private setup. I do an LV and just before they go to the cath lab. And in most cases where the LV is down, I always take EDP before I do start the case. It just takes a multi-purpose 2 minutes and just check the LVT. The LV is very important.
Okay.
So we are doing IVUS to LED. So
yes, you carry on. They are going to show a case and then they are going to come back to you. So you carry on with comfort and at your own pace.
The last presentation.
And you can always show us
Mohammad
this in
Ishaq
the next
Khan.
Pakistan Live.
Mohammad Ishaq Khan, PTMC with Vino Arterial Railroad method. Online. Mohammad Ishaq Khan is online. Can you hear us, Mohammad Ishaq Khan? Okay.
The topic for today's presentation is PTMC with Veno Arterial Rail method. I'm Dr. Muhammad Ishaq Khan from Peshawar Institute of Cardiology.
Dr. Ishaq, can you please turn on your camera?
Yes, sir.
Yes,
our patient was a 42 years old female with a history of severe rheumatic mitral stenosis and minimal MR. She presented with shortness of breath of NYHA class 3. She was in sinus rhythm. ECG shows sinus rhythm with findings persistent with pulmonary hypertension. The pre-procedural echocardiogram showed severe mitral stenosis with mean gradient of 19 millimeters of mercury, but surprisingly only mildly dilated left atrial diameter with severe tricuspid regurgitation and no LA or left atrial appendage clots. Her Wilkins score was 8, so she was planned for PTMC. Routine right femoral route was taken. After crossing the interatrial septum, the Inouye balloon was tried to negotiate through the mitral valve but failed, most likely due to the very tight stenosis. So after struggling with the balloon for some time, we decided to try the septostomy a bit higher to better help negotiate the balloon. But that didn't help either. So then a supportive implants wire was taken, and that was tried to offer a better support, but we also failed over there. So then it was decided to look for other options. While the And the literature offers different methods. Loop method, we did try the loop method, but it is usually successful when we have an enlarged left atrium. In our case, it was only mildly enlarged, so we couldn't do that. Another method is balloon flotation catheter, in which Van Grant's catheter is used to cross the tight mitral valve. Pre-dilatation with peripheral angioplasty balloons are also used. In the end, we opted for the rail or loop method. For the veno-arterial rail method, we took a GR catheter through the Mullen sheath into the left atrium, which guided an exchange length Terumo wire, which crossed through the mitral valve into the left ventricle, and then through the aortic valve to the aorta. And then the balloon was tried to negotiate. So as you can see, every time the balloon was pushed, the wire would come down, and we were not able to cross the balloon with this technique as well. So it was then decided to further push down the wire into the descending aorta and snare it there. Here you can see the wire being snared in the descending aorta. Although it was snared, but it was kept lax. This is the final position of the legs Terumo wire, all the way from the left atrium into the descending aorta. Then the balloon was, we were able to cross the balloon through the mitral valve. Here you can see the final dilatation of the balloon with excellent results with almost no waste left in the balloon. After the dilatation, the mean pressure gradient dropped down to 4 millimeters of mercury. The patient was shifted with stable hemodynamics into the CCU, and later on, the mitral valve area through transthoracic echo was 1.8, almost 1.8 centimeters square with pressure uptime of 125 milliseconds and only mild MR. The take-home message is that in a difficult to cross mitral valve during mitral balloon commissurotomy, the veno-arterial rail or loop method can be used easily for a successful procedure. I thank you all.
Ishaq, please be with us for next 15 minutes. Don't leave, okay?
Right, sir. Okay, sir.
So this was an interesting case in which a snare was being used to hold the wire. And there are certain case reports have been mentioned, 2 or 3 in India, in Indian Heart Journal. So in such cases, different methodology was being used for doing PTMC with the no balloon. What we used to do is we switched to multi-track balloon catheter in such cases. So I want to have an opinion from the panels. Or
what is the risk of damaging the left ventricle, some cheesecake type of effect when you use this veno-arterial rail? Because that's usually when you use, you know, these 0.35
with the no
wires.
technique is very less.
No, when you do a veno-arterial, they pull the wire out.
The wire has been snared from the arterial side, has been pulled down.
So now the whole left ventricle
and they pushed the inner balloon.
No, I understand. But when you do this wire and you snare it out, the whole anatomy of...
Not snare it out, they just snare it and just tag it inside.
So you have, but it's still...
Okay, I will just have a comment especially on this. This was done in our institute. So the question that sir is asking, this is the very valid question. Sir, there is almost always chance of the Swiss cheese effect, but we have to lax the wire from the arterial side. Whenever we have crossed the mitral wall and it was just crossing the LV to the aorta and then snare through the femoral artery, then while passing the balloon, and we have to make sure, especially by doing frequently the transthoracic echo just to see that where or why is the same position or not. The important thing here is whenever we are going to cross the mitral veil and whenever we are going to balloon, we have to lax the wire from the arterial side. The important issue here, ideally, the wire should be removed. Ideally, the wire should be removed and the normal base to apex of the mitral veil balloon should be achieved. because the normal conventional base traffic position is the best for the NOA just to prevent the MR, etc. But we have tried so much time, especially with this lady, that we were afraid if we have some mishap and we were not able to keep the wire there, we may lose the balloon. So that is why we have keep the wire in the descending aorta snare, but just legs whenever we have inflated. There is definitely chance of the MR there, but in the interior mitral leaflet perforation, but fortunately that was...
Why I say this is when you are inflating the balloon, normally the NOA, you know how it points.
Yeah, yeah.
But look at where it was pointing and look at the anatomy of how
Yes.
the wire was going. So
Yes,
this is a very important point to remember,
Yes,
that
sir.
we do it in other cases as well, for pulmonaries and others. You need to be very careful.
Yes, sir. Especially the mitral regurg and interior mitral perforation risk is almost always there. And the important thing, you have to relax that wire just to keep that complication to the minimum.
Shazib, when you have crossed and you have an extra support wire,
Yeah.
the extra support wire, if you relax or otherwise, it won't behave as a floppy wire. So it's very dangerous that you
Yeah,
use this,
so-
number one. Number two thing, why don't you have used a 12 millimeter PS balloon to pre-dilate you have the extra support wire, you have pre-dilated the ostium of the mitral valve, and then you go with your regular NOA balloon technique.
Yes, this is a very good question, sir. I agree with you, especially when we are using the support wire, the implants. We have tried first, we have crossed this mitral valve with the implants, the support wire, but even with the support wire, we were unable to cross the balloon. So when we were just snaring this, so we have just used this Tiromo, that was not just the gliding wire, not the super support wire. So the other thing you have mentioned, we were first discussing that option that we have to pass the peripheral balloon, and we have just prepared that, but ultimately we have decided it may not work. If we are going to negotiate just passing through the septal, the intra-atrial septum and then through the mitral, it may not occur. But definitely that was our mind, and first we were discussing that option. So that was...
Shazib, it was a nice case and nicely done, but I have query. We are using this balloon, but unfortunately, you are saying that you have tried this balloon on extra support wire.
Yes, sir.
But lumen of this balloon is very narrow. How that extra support wire got room to this balloon, number one. Usually, once we stuck in these kind of cases in PTMC, we usually unable to take balloon on other wires except the wire which comes in the pack of this balloon. So probably that's the only...
No, yeah, the wire, yeah, you are just saying about the curly wire or the... We have crossed first that curly wire, it didn't work with that, then again with this gliding wire, didn't work with that, again with the supra-stiff wire, didn't work, and at last we have snare for support.
How you managed to take this balloon on super stiff wire?
Because we were unable to cross this balloon over super stiff wire. That is why we have just for the support purpose we have snare, because it was not working with any support wire. So this was just last option. The other one, Tarisagir mentioned, we were about to plan that. We have just deliver the peripheral balloon just to pre-dilate. But in land, this was just in our mind that we have worked so much, tried so much support wire. We will just snare that in the arterial and just will keep that as a support umaya.
Okay.
Move on, please.
Can you show us the file at NICVD lab, cath lab?
What he is trying to ask is it compatible?
Okay, are you there, Naveed?
Yeah, it is.
Naeem, Naveed.
Actually, still busy with our case. After POD, we are trying to wire the circumflex. It is getting a bit difficult, but we are trying to wire it. And yeah, and we did IVUS from LED to left main. That looks okay. So our plan is definitely to go provisional. We are trying to wire this up, and we'll see it. Otherwise, circ looks okay. There is symmetry flow and no symptoms. The ECG is fine. Patient is stable. So we most probably will go.
As far as I concern, as far as I see, the haziness and the ostium of the circ looks like because of the wire bias. It doesn't look like dissected. And to me, I think that we can leave it as it is, and we leave it to the panel to decide that if you want us to wire again and see. But after the pod, the flow is okay. And whatever I see, it looks like it's just a wire bias. If you pull out the wire, the thing will be okay. But we are trying
Naveed,
to
I think you're right. I wouldn't, as Sohail mentioned, if the patient's stable and even if there is a haziness there, you pull the wire out, either the soft part, and I wouldn't recross again, and you can always bring the patient back.
Can you show us the final view in an AP caudal position, the final view?
And maybe by pulling the wire a little bit back in the soft portion over there.
Naveed, pull the wire back, soft portion. So pull the wire back and then take a AP caudal view. Yeah, pull the wire back. और कर लो थोड़ा. बस ठीक है. Now let's take a picture now. Yeah, looks pretty okay. I think that's fine. That's fine.
Okay, I think, thank you very much. It's a great case again from an SCVD. Thank you for showing very interesting cases, and I think we are going to have the last session of the meeting today. So we are going to end this session.
Yeah, it was nice presentations by different presenters, especially from Tabba and from Peshawar, and nice cases from NSAVD. Thank you.
Can you just disconnect them? Okay, so we are going to have the last session of the day. Before concluding, it's going to be brief, and I'm sure everyone must be waiting, especially the fellows. I think everyone submitted great cases, and Dr. Arslan is going to just show you the total numbers and what happened and how he selected. And then the award announcement will be there. So I'll hand it over to Dr. Arslan. He has done a lot of work to go through all these cases, and I really hats off to him, spent days and nights to really, there were like almost more than 70 cases to go through all of them and sending to everyone to get their opinion, and then getting them back, and then again going through it, to which he's going to tell you how the whole process was done. It was really very painstaking, loading all the images and calling them back and all those kind of things, and we really, really appreciate his hard work and effort. Thank you very much.
Thank you, everybody. So I would like to request Professor Nazir Memon to take a seat on the stage, and Professor Nadeem Saab, the President, Professor Zubair Akram, Professor Tahir Sagir Saab, and Professor Tariq Ashraf Saab. So I'm going to give a very brief review of how the cases were selected for this conference to be presented here, and how were the best 3 cases selected. Can we see the slides here? Okay, so we observed quite a bit of enthusiasm the way we received the cases. So there were a total of 72 submissions that we received, and through an online system that you all know. And then there were certain, like 16 reviewers senior guys selected from the country, and they were like paired up, and these cases were sent to them for review, and they were blinded about this case submitters and the institutes. Like the cases from Karachi were sent to Peshawar and Lahore, and the case submissions from Lahore and Islamabad were sent to Karachi. So there was a whole mix and match going on. Still, the reviewers didn't know where the case is coming from and who has submitted the case. This was the certain selection criteria that was forwarded to reviewers, how they are going to mark the cases and on what basis. Then we received all this data, and the individual scores from the reviewers were added up, that you can see in the last column. And those with the highest scores, the top 15 were selected according to the program of the conference. We could accommodate 15 cases in the conference. So the top 15 were selected to be presented here, and they have been presented in the conference. So among these 15, there was a separate panel of international experts that reviewed the most challenging, most interesting cases. They sat together online, and they went through all the cases, and then they debated upon the cases and built a consensus about the top 3 cases. That's how the case number 1, 2, and 3 were selected. And those guys are just going to receive their awards now. So I would like to request Mr. Tahir Sagir Sahab to announce the best cases here.
Okay. So the 3 best cases that are being selected. The third one is Abdul Salam from Dabba Heart Institute. I would now like to request Professor Zubair Akram. The third prize is for 50,000, presented to 50,000, 50, presented to Salam Sahab by Professor Zubair Akram. The next prize for the second best case is PTMC with veno arterial method by Muhammad Isa Khan. He is not here, so his prize will be received by Shahzeb. The price is of 75,000 Pak rupees. I would now like to request Bashir Hanif Sahab to give his prize to.
I think Ishaq is there online with us, and on behalf of PSIC Council, I must congratulate the colleagues from Peshawar Institute of Heart Diseases. You know what, I have been told that this institute just started a few months back. We are the largest contingent of cardiologists coming from there, and their presence was spectacular, so were their performance.
I would also request that in the future, I think we should make an attempt. There are like half of the Peshawar Institute of Cardiology faculty and people are here, but the person who is supposed to be presenting, he couldn't come. So he should have come here too. That would have been nice.
Now the first prize. Now the first prize is the best case is retrieval of dislodged stent from the stent balloon, Shehzad Ahmed. I would now like to request Professor Nadeem Rizvi to give. जी बताता हूँ मैं. साथ एक और बात भी बताऊंगा. The reward money is of 1 lakh. ये हमने बता दिया आप लोगों को, एनवेलप में वैसे है कुछ भी नहीं. बाद में सोसाइटी आपसे राब्ता करेगी. ओके, थैंक यू। बाकी जो कुलीग्स हैं जिनके केसेस सेलेक्ट हुए हैं उनको सर्टिफिकेट जो है सोसाइटी की तरफ से ऑफर किया जाएगा।
Thank you very much, Tahir. Okay, so it's the moment. I think there's a request from Professor Tariq Ashraf that I think probably we should try all those cases who have been presented, and especially those first three, that they should write the cases and send to Dr. Tariq Ashraf for the journal. So that it can be published in the journal as well. So that will be great. And I think all these fellows, we should encourage that keep collecting the cases throughout the year. And whenever you get it, you should be sending to the journal and maybe present it. Next time we will probably have bigger awards. Last year, this time we couldn't because we don't know what's going on with the COVID, but otherwise we could have sent to different conferences and all those kind of things. So you should be keep collecting the cases, interesting cases, whatever is there, and shouldn't wait till we start announcing it, and keep sending those cases maybe, and we can keep selecting, and so that we have a better, more like interesting cases for presentations. Okay, so I think at the end, I would really want to thank all of you who have been here despite all these COVID situation, and all those who are present on Zoom also. As I said the other day also, our attendance was alhamdulillah over 1100 people were on the Zoom, and a lot of people were here as well. We were not really expecting that we will have that many people. I know we could not really give you too much time in between to rest, but unfortunately the agenda was so jam-packed and I had to finish it in a certain time, so we couldn't, but next time we'll make sure this doesn't happen. A lot of things really had to be jammed up because of the time difference with all different countries, especially the live transmissions from US, UK, and Turkey, as well as China, and those people couldn't come in different, and there was a significant time difference, and it was not easy. But I really want to thank, and I also want to thank all the council members, the scientific committee who really worked very hard to do this. All the industry sponsors, I think obviously without their support this would not have been possible, and especially our platinum partner from CATS, and also gold partners Medtronic and Formuvo and all the rest. We really thank, and we hope that this kind of support will continue in the future and will continue. You have seen that it was a purely academic content, nothing else. So thank you very much. And last but not the least, I think Orbitz has really worked very hard with us. This was their first time. Last year we couldn't do it too. But I think except few glitches which can occur even in any international conference, overall things went very well. And everyone internationally, I've been getting messages all day and night that the quality of the transmission and overall conference was comparable to any of the international standards. And I know people have really worked very hard, all of them. I think Wes, the CEO, Ramsha has worked very hard day and night. She was up all night to call all these faculty, and really worked very hard. Like at 4 o'clock in the morning, 5 o'clock in the morning, she was available to respond, and worked hard. Similarly, Maria and Zohaib. I don't know everyone else's name, but I think Zohaib was the person behind all these technical things. So really, I think there should be a big hand for him. He has worked hard as well. Wes, if you quickly want to say something about your team, I'll just give you a couple of minutes.
थैंक यू वेरी मच। मैं सबसे पहले अपनी टीम जुहेब CTO जो हमारे एज IT हेड देख रहे हैं उनका शुक्रिया अदा करता हूँ। इसके साथ पूरी टीम ने काम किया है, जैसे कि जिसमें महेश हैं, रमशा है, मारिया एंड तैयबा, ताहा ट्रांसमिशन के साथ साथ ऑपरेशंस भी देख रहे हैं, रिजवान, और हमारे जो चीफ जो सारी ट्रांजेक्शन्स को देखते हैं वकार साहब बैठे हुए हैं। मैं आप सबका शुक्रिया अदा करूँगा, आपने इतनी अच्छी अपॉर्चुनिटी दी और इसमें हमने काम किया आपके साथ। थैंक यू
वेरी मच। एंड द लास्ट, डू यू हैव द नेम ऑफ दैट? Okay, so the last one which I've been telling for the last few days, that those who have been visiting the exhibit online, virtual, So we'll see what was the ballot and who got the tablet, which again will be given later, but we will announce that if we have it ready. From that, the ballot, the name is, I think it's probably Dr. Jobi Ubaidullah Popal. His email ID is here, ubaid10144@yahoo.com. So this was the only information available. So if he is hearing this, he will get a tablet. So this was one of the ballots for those who visited exhibit site. Okay, so I think that's it for now. Till we see you next year, inshallah. In April, we'll be announcing the date shortly. And we would like to have everyone's participation. If any few last words from the President, Dr. Nadeem Rizvi, please.
Thank you very much. I mean, I'd like to thank Hanif. I've been attending conferences for the last 30 years, but never have had to get up at 7 o'clock. And the pressure, the quality of this conference was such that I felt that I had to get up at 7 o'clock. I'm telling you seriously, I've never ever got up for 2 breakfast sessions in my life. That I had to get up here. So this just shows 2 things, and it's the terror of Dr. Bashir Hanif. I'm calling it terror, but actually it is the respect that I had for the quality of program that Bashir and his team and the council, including Zubair, Tahir Sagir, Arsalan in the background. I'm sorry I haven't mentioned you before, but I appreciate the quality. I mean, in the end, the fellows are the foundation on which this society stands. You have to understand this. You know, so you are the people who will be the future of this, and your attendance, if you just keep on attending these conferences and presenting and giving your cases, and this is the time, you will, the Greg Stones and Cindy Grinds and all of them, you know, there's no reason why you people cannot be compared with them. So I think that for the next Pakistan Live, I expect, I mean, this is the only time I've seen the last day पे और आखिरी जब ख़त्म हो रहा हो, उस वक्त कभी मैंने 20 से ज़्यादा लोग कभी बड़ी conferences में नहीं देखे. यहाँ तकरीबन 100 बंदा इस वक्त है. So I think this just shows the success of the conference, and I expect next time the fellows' participation and would be much more. So in the end, I'd like to thank Bashir. It was an honor and a great pleasure, and the quality that we have now maintained, it will be very difficult replicating this. Thank you.
Dr. Nadeem Ahmed, you want to say something? Please go ahead.
Thank you very much indeed. I think I represent a slightly older generation, and I wish to thank organizers, particularly Bashir and his team. They have done a wonderful job. They have kept me awake as well as available from day one, that is session 1, and this is session ending. So all credit to his leadership and his team. That's number 1. Number 2, I know the society will be run by younger people. But I think people like myself will also have a duty. And the duty is to encourage you by our presence and by our prayers. Thank you.
Thank you.
Okay, thank you very much, and Khuda Hafiz.